We are heading now for our next presenter. Our next presenter is Dr. Yara Bahaa, a teaching assistant of pathology at Faculty of Medicine, Beni Suef University. And her presentation is entitled Histological Puzzles, a Tumor's Hidden Patterns. Presentation is under supervision of Professor Dr. Noha Abdulhafiz Hilmi, a professor of pathology and head of the pathology department at Medical Research Center of Excellence, National Research Center. Dr. Yara, you are with us? Dr. Yara, can you hear us? I can't hear you,
Yes,
Dr. Yara.
doctor, I am here.
Yes, now I can hear you. Okay. Okay, I see your screen and you can go on. Okay.
Good afternoon, everyone. Today's presentation is titled Histologic Puzzles, a Tumor Hidden Patterns, presented by me, Yara Mohammed Ibrahim, Pathology Teaching Assistant, Faculty of Medicine, Beni Suef University, under supervision of Professor Dr. Noha Abdulhafiz Hilmi, Professor of Pathology, Head of Pathology Department at the Medical Research Center of Excellence, National Research Center. Today, I'll present 3 renal tumor cases. I will start by summary of the 3 cases. The first one is a female patient, 32 years old, performed radical nephrectomy. It showed a fairly defined tan pink to gray mass, measured 5 cm in greatest dimension, pathologic T1B stage. The second case is a female patient, 29 years old, presented with a fairly defined yellow-brown mass, which showed hemorrhage and focal hard foci, measured 6 cm in greatest dimension, pathologic T1B stage. The third case is a male patient, 75 years old, had a poorly circumscribed soft tan pink mass, measured 9 cm in greatest dimension, and it was infiltrating renal sinus fat. Unfortunately, we don't have the cross picture. It had pathologic T3 stage. Moving to the microscopic features, the first case, as we can see in figure A and B, it had nested pattern of epithelioid clear cells. But we can also see in picture C and D, we can see widespread sammomatous calcifications or sammoma bodies. The second case, as we can see in figure A, it had also nests of epithelioid clear cells, but here we can appreciate the presence of papillae. The papillae were lined by clear epithelioid cells. The core of papillae also showed clear cells. The lining showed occasional cells with eosinophilic granular cytoplasm. There is a higher power of the papillae. The case showed extensive hemorrhage, so we can appreciate siderovages here. It also showed calcification, which was evident grossly. The third case showed predominantly, it was performed predominantly of solid and nested pattern of cells with eosinophilic granular cytoplasm. It also showed tumor necrosis.
Share screen, doctor.
The summary of the 3 cases, the first one was formed of clear cell pattern with sammoma bodies. The second case has a mixture of clear cells and papillae. The third case had solid pattern. So what could these 3 cases be? Do they have a common diagnosis or do they have different diagnoses? We performed TFE3 immunostaining. It was positive for the 3 cases. Here we can appreciate the positive strong nuclear staining in case 1. And this picture shows the positive moderate nuclear staining in case 2. We don't have pictures of case 3, but it was also positive. So the diagnosis is TFE3 rearranged renal cell carcinoma. TFE3 renal cell carcinoma is now in the 2022 WHO classification under the molecularly defined renal cell carcinomas. Previously, in the 2016 classification, together with the FEP rearranged renal cell carcinoma, it was under the MIT family translocation carcinomas. What are TFA3 rearranged renal cell carcinomas? They are characterized by translocations involving the TFA3 gene, which is located at the XP11.2 locus. The TFA3 gene can have multiple fusions with multiple or a wide list of proteins. The 3 most common are BRCC, ASP, SCR1, and SFBQ. The formed chimeric fusion proteins have varying functions, which may explain the different histologic features observed in this tumor entity. Regarding the microscopic features, what we can see, so we can suspect this diagnosis. The most common is a mixture of papillary architecture and epithelioid
Doctor,
clear
please,
cells.
the screen not shared, please, doctor. The screen not shared.
The screen is
Sorry, doctor. We see the screen clearly. If you don't see the screen, check your connection, please.
also, if we see abundant samoma bodies, we should suspect this diagnosis. It may show a solid trabecular or microcystic pattern, mimicking any subtype of RCC, including clear cell renal cell carcinoma, papillary renal cell carcinoma, and the clear cell papillary renal cell tumor. So the message of this presentation is that the wide spectrum of morphology seen in TFPE3 rearranged renal cell carcinomas emphasizes the need to consider these carcinomas in the differential diagnosis of unusual, difficult to classify RCC occurring in both children and adults. This diagnosis may be not straightforward on H&E slides, so the identification of TFPE3 gene translocation, whether by immunohistochemistry or FISH, is required to confirm the diagnosis. Regarding the cross findings, we know that some types of RCC have characteristic colors, but this entity doesn't have a specific macroscopic appearance. But most importantly, they don't share the macroscopic features of clear cell renal cell carcinoma. So what age group do these entity occur in? They were first recognized in children. They account for less than 5% of renal neoplasms in children. 40% of these have been classified as TFPE3 rearranged RCC. The frequency in adults may be underestimated, and we know why, ranging from 1 to 4% in different studies. Although as magnitude-wise, they are more in children, but the number of adult cases outnumbers the pediatric ones because of the higher incidence of RCC in the adult population. So do these tumors have risk factors? The only known risk factor is prior exposure to chemotherapy. Up to 15 patients of these tumors had a history of prior chemotherapy exposure. Regarding immunohistochemistry, the most sensitive and specific immunohistochemical marker is TFPE3, but it is technically challenging and is subjected to it is affected by suboptimal fixation. So FISH is considered the gold standard. Regarding FISH, TFPE3 break-apart FISH assays can provide molecular confirmation of TFPE3 rearranged renal cell carcinoma. It suffers less from the technical and fixation issues associated with the immunohistochemical assay. However, FISH or RNA-ish techniques are limited in most labs. Therefore, looking for an immunohistochemical panel using most available markers to recognize these tumors might be worth it to correctly identifying them. So what markers can we perform regarding the differential diagnosis we are considering? TFPE3 rearranged RCC are positive for cathepsin K and HMB45. It is negative for CA9, cytokeratin 7, cytokeratin 20, and GATA3. SDHP and fumarate dehydrogenase should be retained. If we consider papillary renal cell carcinoma in differential, cytokeratin 7 is the gold standard. It is positive in papillary renal cell carcinoma and negative in TFPE3 rearranged cell carcinoma. In chromophobe renal cell carcinoma, exhibition of cytokeratin 7 and parvalbumin along with the absence of S100A1 is characteristic is chromophobe renal cell carcinoma, whereas strong and diffuse labeling of S100A1 along with underexpression of cytokeratin 7 and parvalbumin are typical of TFPE3 rearranged renal cell carcinoma. If we are considering clear cell renal cell carcinoma, CA9 is negative in TFPE3 rearranged renal cell carcinoma and positive in clear cell RCC. Clear cell papillary renal cell tumor, we perform GATA3, cytokeratin 7, and CA9. They are positive in clear cell papillary renal cell tumor and negative in TFE3 rearranged RCC. This table summarizes the immunohistochemical findings in the differential diagnosis we encounter. Regarding outcome, they are highly variable. Some cases are indolent, some cases show rapid progression. Overall survival is similar to patients with clear cell RCC, but they are more worse than patients with papillary RCC. Although several studies have claimed that TFE3 and rearranged renal cell carcinomas in children have a relatively indolent course, the review of literature shows a high percentage of aggressive cases in young adults. A larger tumor size correlates with aggressive behavior. And interestingly, the presence of necrosis, but not the nuclear grade, correlates with aggressiveness, as we had necrosis in case 3. And these are the same prognostic characteristics reported in chromophobe renal cell carcinoma. Fusion subtypes also impacts the presentation. ASP, SCR1, TFE3, RCC were significantly more likely to present with regional lymph node metastasis than those with BRCC, TFE3 fusion. Most of the former patients remain disease-free without adjuvant therapy, hence a locally advanced stage will not predict adverse outcomes. All patients who presented with distant metastasis had ASP, SCR1, TFE3 RCC, and these patients had poor outcomes. These references I used. Thank you.